Before we get started, I'll introduce our speakers. Dr. Tami Bar-Shalita's research focuses on understanding sensory processing, including pain, as a predisposing factor or a contributing factor in various health conditions. She is a senior lecturer in the Department of Occupational Therapy, Faculty of Medicine, heading the graduate program, as well as the Sensory Integration Lab at Tel Aviv University. Dr. Yelena Granovsky is a research neurophysiologist. She joined the research team in the Lab of Clinical Neurophysiology in Rambam Healthcare Campus at Technion Medical Faculty, where she is now a senior lecturer. Mary Kalingal Levi is an occupational therapist and doctoral candidate in the Occupational Therapy Department at the University of Haifa. Her work is focused on studying the pain experience of autistic people using qualitative and quantitative approaches. These webinars are made possible thanks to generous donor support. If you'd like to contribute, please visit our website at autism.org. And now I will turn this over to our speakers.
Thank you, Denise. Hello, everyone. We're very excited to join you here today. And first, we would like to thank the ARI for this opportunity and to extend this to all of you joining here today. With me here today are Dr. Granovsky and Mrs. Kalingal Levi, a Ph.D. student in this project. Before we begin, I would like to thank Professor Weisman-Fogel, a PI in this project, to walk this journey with us, and to thank Mrs. Hoffman, a Ph.D. student in this project as well. So indeed, this study is performed in 4 institutes. Okay, now, so while sensory atypicalities or sensory alterations have long been recognized in the autism realm, pain granted some attention in recent years only. So in this webinar today, we will work through the ties between pain and non-painful sensations, the other sensory systems, and specifically, we will be presenting our research quantitative and qualitative findings. So from sensory and pain behavior to neurophysiology in autism. Before we begin, we recognize that the use of person-first versus identity-first language is a source of debate and controversy. In this presentation, we have chosen to use person-first language in alignment with the ARI publications. No further disclosures. So our objective for today's talk is to better understand the pain perception in autism and its link to sensory alterations. Today, I will start with some background about sensory modulation dysfunction and pain, and then present our quantitative findings, at least some of them. Mrs. Kalingal Levi will present our qualitative findings, followed by Dr. Granovsky, that will talk about the neurophysiology of pain in people with autism. More specifically about my part, so the overview, I will actually walk you through our journey that led to this research project, starting with the sensory perception, the link between processing non-painful and painful sensations, and lastly, how pain in autism is perceived. Then I will present our behavioral quantitative findings. So briefly, Mary, one behind, So briefly, starting with understanding the centeredness of the sensory perception to our life and to functioning. We are all surrounded and maybe bombarded with lots of sensory stimuli all the time. It is important to understand that our efficient reaction in response to what is happening around us is dependent on the sensory modalities involved in a particular situation. The more, the better. For example, if I smell smoke, the olfactory system does not detect direction. So I'm clueless as to where is this smoke coming from. if I hear the burning sounds, I then can turn my head towards that sound and use my eyes to try and locate the sound. Once I locate it, I then can choose the most efficient reaction, run away, call for help, or realize I cannot do anything about this. So we are talking about a multisensory perception which is shaping our behavior. Indeed, a study measuring reaction time found that when the visual and the auditory cues came together in blue, reaction time got shorter and faster. So this is a rule of thumb. Mary just won before. This is a rule of thumb, information from number 7. I'm sorry for that. No, Mary, number 7.
I'm sorry, something is wrong with the... Just a second, okay? I'll come back. Something is stuck in the presentation.
Yeah, I'm here, okay? So this is a rule of thumb. Information from multisensory modalities, when intact, elicits a more efficient reaction. Stay there, it's okay. And further, the understanding to date is that sensory processing is the cornerstone for perception, cognition, and for any higher information processing, and is a process critical for socialization and communication development. This model, which was developed by Wallace, suggests as one that explains the development of ASD core symptoms. So when our reactions to the stimulation around us is such that hinders our function, we may be indicating sensory modulation dysfunction, or SMD. SMD has 3 types, and in this talk, we will focus on the sensory over-responsiveness type, or SOR. This condition denotes that the responses to daily, ordinary, non-painful stimuli are much amplified, causing suffering, even pain, and reducing the ability to function efficiently. These may be best demonstrated in this clip. Mary, please.
Take my hand.
Okay, thanks.
I'm not naughty.
So trying to understand this behavior and utilizing the pain research lens, we wanted to understand whether this behavior is linked to pain. So what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. It is a warning neural system which intended to also promote analgesic protective behaviors. When lasts for over 3 months, it is considered chronic pain, and this is a pathological condition. Please note, importantly, the pain matrix, the brain network processing pain, comprising 3 dimensions, also processes non-painful sensation. So it is imperative to actually study pain in sensory modulation dysfunction. And this is what we actually did. we began in testing the pain perception in neurotypical children and adults with sensory overresponsiveness, applying experimental pain in the lab. We utilized psychophysical approach, meaning the researcher controls the intensity of the stimulus and assesses the intensity of response. We found that children and adults with sensory overresponsiveness, otherwise healthy in red, on your left, the two ones on your left, rate the pain intensity higher. This is termed hyperalgesia. And the pain lasted longer, and this is termed after sensation. You can see it on the two figures on your right. The latter was tested over 6 minutes after stimuli termination, and while controls in blue show pain reduction over time, children and adults with sensory overresponsiveness in red did not show this pain reduction. Now, importantly, both these markers are excitatory signs of brain activity. In the normal brain, excitation and inhibition within the cortex are well balanced. If the balance is disrupted, excitation exceeds inhibition and the cortex starts producing abnormal patterns. These abnormalities can be detected in majority of cases and can be recorded from the scalp by using EEG. So since we found excitatory signs, we turned from psychophysical approach to neurophysiology using EEG. We first asked whether brain activity in sensory overresponsive individual is basically different. We tested individuals in resting position with eye closed. Finding indeed indicated that the peak power at alpha band was weaker in sensory overresponsive adults. You see it at the bottom right, compared to controls. And on your left, you can see the same, but via brain maps distributions in 4 individuals, 2 of them with SOR with sensory overresponsive at the bottom, and the above are control. So our findings are similar to those found in individuals with hypersensitivity to pain. So it is important to note that in neurotypical, healthy individuals with sensory overresponsiveness, it seems that behavioral responses and neurophysiological activity are tuned. These are some of the papers we published on pain and sensory overresponsiveness, and we were able to conclude that SOR, sensory overresponsive individuals, have an excitatory type of a pronociceptive profile, meaning they're hypersensitive to pain, which is a predisposing factor for developing chronic pain, which brought us to propose the SMDolor Model, explaining pain in sensory overresponsive individuals. Based on the excitatory type of the pronociceptive profile, we argue that the excitatory inhibitory imbalance, or EI imbalance, underlies the amplified responses to non-painful and painful sensation in individuals with sensory overresponsivity. We will soon hear more about the EI imbalance for Dr. Granovsky. Since EI imbalance is one of the theories also explaining autism, and since sensory overresponsivity is very common in autism, we turned to investigate the pain domain in autism. So when we set out, the widely held belief was that people with autism are indifferent to pain, and this was based on their self-injurious behaviors. And at that time, we found 2 reviews, each had few papers, but different conclusions. Most of the papers reviewed in both publications were case studies or observational studies. One of these observational studies by Rataz, testing responses to venipuncture, the authors observed that although the typical population were routinely given anesthesia before venipuncture, in the autism population, anesthesia was applied less than 50%, which maybe show the consequence of this widely held belief. Okay. Moreover, the few laboratory studies found conflicting results. It should be noted that this widely held belief that people with autism do not feel pain, also is expressed in the DSM-5, where under the RRBIs, it includes apparent indifference to pain or temperature. In line, approximately 40% of parents reported that their child shows either reduced or greatly reduced pain sensitivity. However, in a chronic pain clinic among children and adolescents with chronic debilitating pain, 30% were found with autism, who most were not diagnosed previously. So actually, there is a misdiagnosing of chronic pain in autism, as well as misdiagnosing of autism in chronic pain conditions. Untreated or hidden pain can cause plasticity changes in the central pain system in the brain, amplifying pain sensitivity, and may possibly lead to pain chronicity and suffering. Of concern is the possibility that these also precipitate late referral, diagnosis, and intervention, provoking actually compromised healthcare and specifically compromised or pain treatment neglect. So now I finished with the background on sensory and pain in autism, and now we'll go forward to our quantitative findings. So in our research project, we tested 151 adults, 69 with autism, and 89 healthy controls, which were sex-matched. This is the largest pain study in autism to date. High-functioning autism was verified according to the ADOS-2 and the WASI, the Wechsler. Looking at figure A, using heat pain stimuli in the lab, we found that both autistic in red and the control group in blue demonstrated an increase in pain ratings along the temperature increase, meaning their dose response is intact. Yet, individuals with autism in red showed significant higher pain ratings in response to each of the 3 heat stimuli. Over to figure B, when we tested the analgesic endogenous capability by evoking 30-second pain, we found that while controls in blue demonstrated a significant pain reduction, individuals with autism did not. The importance is that these experimental pain paradigms models the clinical, the daily pain, meaning individuals with autism cannot physiologically inhibit their pain effectively enough. Now, testing within the autistic group on your right, we found that those using psychiatric medication had higher scores on the sensory modulation measure, which is the sensory responsiveness questionnaire, probably experiencing more severe clinical manifestation. Of note, the mean score of those using medication is indicating actually sensory over-responsiveness, the mean score as a group. Taken together, people with autism are pro-nociceptive, more sensitive to pain, inhibit pain less efficiently, and those who use psychiatric meds may have sensory over-responsiveness as well. I cannot go over all the experimental pain testing we performed, yet pain hypersensitivity was repeated in different test paradigms. But more importantly, testing the consistency of the results between these different tests and within each group separately enable us to conclude that both groups show similar correlations, demonstrating similar response consistency, which suggests that in people with autism, responses may be considered reliable. So we now wanted to know whether those with sensory over-responsives comprising 40.6% of the ASD group are clinically higher in symptom severity. We utilize many measures, but here are 3 demonstrating that those with sensory over-responsive report on higher anxiety trait. They were higher on the autism spectrum quotation, and with more participation restriction measured via the World Health Organization Disability Schedule. So to conclude, the symptom severity of people with autism and sensory overresponsiveness is higher compared to those autistic with no sensory overresponsiveness. So now I will hand it to you, Mrs. Kalingal Levi, our PhD candidate student.
Thank you. So as you've heard, our study was a comprehensive quantitative study aimed at exploring the pain processing and modulations mechanism in people with autism. We were curious about the similarities and differences between the pain experiences the participants were having in our lab compared to their daily pain experiences. The conversations with them following the research protocol clarified to us that we need to address better the multidimensional nature of pain. Therefore, we decided to reinforce the quantitative method with the qualitative method and enjoy the advantages of both precise measurement and diving into the lived experience. In the qualitative part of our study, the phenomenological approach was used. The phenomenological approach is a form of qualitative inquiry that emphasizes experiential, lived aspects of a particular construct. The inclusion and exclusion criteria were the same as the quantitative part of the study. The sample comprised 15 adults with autism, 7 males and 8 females. Participants were invited to online in-depth interviews via Zoom. Each interview lasted 60 to 90 minutes and was audio recorded. We developed an interview guide and analyzed the interviews by examining thematic content based on participants' descriptions. And this analysis led to 4 main themes: pain sensitivity, pain awareness, pain communication, and pain awareness solutions. So the participants described various pain sensitivity characteristics, as demonstrated here in these 3 quotes. The participants can be divided into 3 same-size groups: hypersensitive, hyposensitive, and neutrally sensitive to pain. While there were heterogenic reports regarding pain sensitivity, all participants reported difficulties in pain awareness, that is, feeling uncertainty about their internal pain experience. This uncertainty consisted of 3 layers: the existence, nature, and severity of pain. The first challenging aspect, the existence of pain, refers to the ability to recognize the presence of pain and to differentiate pain sensation from other physical and emotional sensations, such as hunger or distress. One participant said, "Sometimes I only realized it was pain I was dealing with in retrospect." Another challenging aspect is the nature of pain, which refers to the ability to characterize and nominate pain by its nature, to conceptualize pain in terms of burning, pressure, or stinging, for example. One participant reported, "If someone asked me where or how it hurts, I would not know how to answer." The last aspect of pain awareness is the severity of pain, which refers to the ability to grade the pain intensity and evaluate the risks and implications as a result of the pain. One participant described an event of complex leg fracture. "I could not understand what my body was signaling to me. Is that pain serious?" The participants described the lack of internal information as disturbing, triggering a sense of confusion. The difficulties in pain awareness affect the ability to express pain experience to the surroundings, particularly healthcare professionals. These challenges affect the opportunity to get assistance in pain conditions, since the participants cope with difficulties answering questions regarding pain quality and characteristics. As a result, they describe that their pain is often overlooked and that they are discharged without treatment. For example, many describe not getting analgesics in severe pain conditions. As you can see in the second quote, only on the third day of the hospitalization after hysterectomy, the nurse suddenly came over and asked, "What are you getting for the pain?" I told her, "I do not receive anything." The participants suggested several practical solutions, which may assist them in getting the help they need under pain conditions. The first subgroup of solutions is better suited communication. The participants ask for fewer questions and more concrete possible pain-related interpretations of their behavior. The external assistant should be open, exploring, and toward definition by the person with autism himself or herself. Another subgroup of solutions is environmental adjustments, which enable people with autism better conditions for self-reflection that promote better physical interpretation, including sensory adaptation such as light dampening and noise reduction. The last subgroup is assistive aids. The participants suggested creative and diverse aids to help them recognize, be aware, and better understand their pain experience. One example is the usage of a booklet, which includes a combination of text and pictures to use in the clinic as a mitigation between the clinician and the person with autism. So our research demonstrates that difficulties in pain awareness are a core aspect of pain experience in people with autism. However, it has not been researched until their current study. The challenges that people with autism face regarding pain awareness affect their self-understanding and capability to communicate their pain experience. Challenges in pain communication often result in an untreated pain. The participants suggested practical solutions, which they believe may help them, including better suited communication, environmental adaptation, and the usage of assistive aids. Dr. Granovsky will take it from here.
Okay, thank you, Mary, and hello, everybody. Today, I want to share with you our findings and understanding about pain-related neurophysiological processes in people with high-functioning autism. More specifically, during my presentation, we will talk about spontaneous and pain-evoked EEG responses, as well as we'll talk about functioning of cardiac autonomic system assessed with heart rate variability. As you are probably know and familiar with this view of EEG activity, which represents the electrical activity recorded from the cortex. The electrical activity is not static, but comprised of highly variable neuronal oscillations with a wide frequency range. Researchers divide EEG activity into several frequency bands. The activity in each band has a unique physiological context. For example, the higher alpha power appears at rest, with the eyes closed when falling asleep. Very slow activity at the delta band is associated with regulatory phenomena and refer to our basic physiological needs such as hunger, sex. Enhanced theta activity usually indicates an emotionally aroused state and is strongly associated with activity in limbic system and so on. So in order to quantify spontaneous EEG activity, we have to transform it from the time domain to frequency domain, calculating then the activity or power within each band. What do we know about the resting or spontaneous EEG activity in autism? In young children, it is usually associated with so-called U-shaped curve due to high activity of the slow and fast EEG bands. It was nothing that enhanced activity of slow bands characterizes many neurodegenerative states and diseases, and is often related to antisocial and impulsive behavior or behavioral manifestations. Among the underlying neurophysiological mechanisms of the excessively slow EEG activity are aberrant GABA neurotransmission. This results in excitatory inhibitory neuronal imbalance, as already was mentioned by Dr. Bar-Shalita. And this imbalance occurs due to reduced level of inhibitory GABA-mediated and the enhanced excitatory glutamate-mediated activity. Disruption of neurosignaling in the thalamocortical circuits also takes place, and it's called, this phenomenon called thalamocortical dysrhythmia. Importantly, all these aforementioned neuronal phenomena are also relevant for many chronic pain states. Very little is known about spontaneous or resting EEG activity in high-functioning autism. From the few papers that I could find, including this example, we can conclude that consonant with the aforementioned U-shaped curve, people with high-functioning autism have higher activity and at delta, theta, and gamma bands, while the controls have higher EEG power at the alpha band. However, please note that we're talking about very small sample, only 18 participants in each group. Now we move to the resting state EEG findings from our study that was also mentioned by Dr. Bar-Shalita, but here I'm talking about the subgroup. From them we had a EEG recording. So we're talking about 58 people with high-functioning autism. As you can see, there is a very similar spectral power distribution pattern for both groups, but the autistic people demonstrated higher power at slow, delta, and theta, and at fast beta bands. We further investigated the association between the resting state EEG activity and pain perception. Do they correlate? Among the most prominent findings is a difference between the two groups in their relationships between low EEG activity on the delta band and pain sensitivity. More specifically, enhanced delta oscillations in autistic people were associated with lower detection threshold. Namely, the people needed lower temperature to start feeling the pain sensation. So to conclude so far, the reported enhanced sensory and pain sensitivity in the people with high-functioning autism is associated with enhanced spectral EEG activity at fast and slow frequencies, and higher EEG activity at delta band in the autistic group correlated with the enhanced pain sensitivity. These findings confirm the mediating role of the deficient GABAergic neuronal transmission in autism and in pain. Now we move to the next topic of my presentation, and we will talk about pain-evoked potentials. Let's first understand what is an evoked potential. An evoked potential is a change in cortical activity that occurs in response to an event of some kind. For example, you can see calm person and his spontaneous EEG. Here, surprisingly, events comes, and you can see the responses on the face and on the EEG. When we're talking about pain-evoked potentials, our event is a pain stimulus. Here I show you a picture of the experimental setup for evoking and recording the noxious contact heat evoked potentials, or CHEPs. You can see the stimulating thermode attached to the subject palm, when the EEG is recorded during the stimulation. What do we know about pain-evoked potentials? We know that the evoked cortical responses are detected over all scalp electrodes. The highest amplitude is detected over the vertex, the center. We know that the factors as age and sex influence pain-evoked potentials and amplitudes. It declines in amplitude and takes longer to reach peak with age, and females have higher amplitudes. And most important in the context of pain, the amplitude is highly affected by the stimulation intensity and the perceived pain. As you can see from this figure, high stimulation temperature evoked higher pain-evoked amplitudes. We determined two main peaks of the EPs, called N2 negative peak and P2 positive peak. Both responses have overlapping cortical generator, while N2 mainly originates from the pain and sensory detecting areas, as the primary and secondary somatosensory cortices, insula, and anterior cingulate cortex, and P2 also originates from the mid-posterior cingulate cortex, reflecting mainly emotional and cognitive aspects of pain processing. The amplitude of pain EPs can be considered as objective measure of pain, as it significantly correlates with the perceived pain, as you can see from this graph. Up to date, there are only 2 published papers from the same research group with research performed with males only, referring to the question of pain EPs in autism, reporting higher P2 amplitude, which, as I just mentioned, reflects cognitive and emotional pain dimensions. Analyzing pain-evoked potentials in our study, we included the factor of sex in our model, since about a third of our sample were females. We revealed significant group differences for the N2 potential, namely lower N2 amplitude in autistic people. Another interesting finding was that in contrast to the control groups, where the expected higher amplitudes were detected for females, the females with autism had lower amplitudes than autistic male. This meaning is that sex differently impacts the N2 amplitudes in autism as compared to the control group. So, to summarize pain episode relevance in autism, we show that there is a discrepancy between pain reports and the responses from pain detecting areas in autism. Moreover, abnormal responses in the pain detecting cortical areas in autism are sex-related. Another frequently used physiological measure employed in a study of pain is heart rate variability, or HRV. HRV reflects the functioning or autonomic regulation of the cardiovascular system. As you may know, the cardiovascular system is under regulation or innervation by the sympathetic nervous system, which is active during arousal states, increasing the heart rate and force of contraction. HRV is also under control of the parasympathetic system via the vagus nerve. This system is also activated during states of arousal, but its role is to bring back our organism to the state of homeostasis by decreasing, for example, the heart rate. Another important characteristic of the vagal system is that its activity is also associated with analgesia due to anatomical connections between vagal and sensory system. This mechanism of pain analgesia, for example, is widely explored in the treatment of pain via the vagal electrical nerve stimulation. In order to get an impression about the HRV, we have to record and to process the ECG signal, looking at bit-to-bit RR intervals. Higher variability between bit-to-bit intervals points to higher activity of the vagal or parasympathetic cardiac system. Heart rate variability in autism is broadly studied, as you may see from the results of these recently published meta-analyses. Individuals with autism have lower parasympathetic activity. It was demonstrated at the baseline or at rest, as well as during stressful conditions such as social stress. However, as far as we know, there is not a single published study on HRV related to pain perception in autism. This was one of the questions of our study. We're talking about the same study as I presented the EEG findings. HRV was tested under 3 conditions: baseline or rest, during the exposure to heat pain, HRV reactivity, and during post-pain recovery. As you can see from this figure, the autistic group had lower vagal or parasympathetic activity independently of the recording conditions. However, the reactivity of the system during pain was similar to the control group. We also looked at the relationships between the experimental pain perception and the HRV, and surprisingly found that the 2 parameters were not related for the control group, as you can see in blue. However, autistic people, those who had higher HRV scores, felt less pain. They were less pain sensitive. They had higher pain detection threshold, so they needed higher intensity to start feeling the pain, and lower scores of the perceived pain. Thus, we can conclude that the people with autism have deficient control, but unaltered reactivity over parasympathetic cardiovalve system, and higher parasympathetic activity is associated with lower pain perception, pointing to a protective role of the parasympathetic system in cases of pain hypersensitivity, which is indicative for autism. And a couple of words for future perspectives, research future perspective. We believe that it would be very important to evaluate the role of sex in pain neurobiology and lived experience in autism, and to develop a mechanism-based therapeutic modalities for treating pain in people with autism. Thank you. You are in mute, Tami.
Sorry. Thank you, Dr. Granovsky. And we came to the summary. So maybe first of all, as opposed to the common belief expressed in the DSM-5, we found in the largest experimental pain study to date that people with autism are hypersensitive to pain, have a pronoceception profile, which importantly is a risk factor for developing chronic pain. We found that in people with autism, neurophysiological responses are associated with the perceived pain. However, the qualitative study revealed that there is a gap in awareness and communication of the painful experience. Importantly, the final process in the pain experience is the social communication of pain, which may be observed in autistic behaviors such as self-injurious maybe, or repetitive behavior, and so on. And lastly, Subgrouping the autism population based on the sensory over-responsiveness may help understand the individual autism severity expressed in daily difficulties and participation restrictions, which may guide future precision medicine. We would like to thank our students. Special thanks again for Tela Hoffman, a PhD student in this research project. And of course, again, to our PI collaborator, Professor Weissman Fogel. We also want to thank the Israeli Science Foundation for supporting this study. And last but not least, the participants in this study for their time, effort, and for sharing their experience. And here are some of the publications describing this research project and others yet to come. And before transitioning to the Q&A part, we want to thank you all for joining us today again. So I believe we're ready now for the questions.
Great. Thank you so much to all three of you for being here today and for everybody who worked on this important research. Sensory issues are something that we hear about every day at ARI, so it's such an important part of the experience for autistic people. So it's really appreciated, and we're glad that you could do this. We know you're overseas, and it's the evening there, so thanks for making time. We have a lot of questions for everybody who's still here. Be sure to type your questions in the Q&A section. We'll start with those. There are a few that ended up in the chat, and we'll try to get to those as well. The first question here is, can you talk just a little bit about what you've observed in your work and in your lab about how sensory processing impacts social interactions? Maybe just some very high-level comments about that.
Mary, should I take it? So I'll start, and Mary, if you want, you can add. So I think maybe we can look at it, maybe to look in a principle way that, let's say, when I perceive regular sounds as noise or as aversive, and when I mean regular sounds is, for instance, the fluorescent light buzzing, or the refrigerating working, not to mention a little bit higher toned sounds, and then I cover my ears, I miss out. And this is just maybe only the tip of an example, but I think it can give a very clear principle of how sensory modulation dysfunction actually hinders socialization, because the same goes for touch, and the same goes for taste, etc. Mary, you want to
expand
add?
and say, yeah, please. When I'm busy in sensory aspects of the environment and within myself, I cannot be in touch with others, at least not as I'll do this mark, normally interactions. So I think this is the main thing. I mean, the fact that I'm so busy at the sensory aspects that I cannot, or I will handle with difficulties, be part of, to participate in social interactions. And I want to add that sometimes the visibility of sensory perception difficulties is strange, and others may not be, may not want to be close, or to be in interaction with someone who seems to be not in the mainstream. Let's say it like that.
Right. So that stress that they're experiencing is interfering with their ability to attend to the social interaction. Social interaction is lower down in their priorities, not intentionally, but out of necessity, because of how their parasympathetic system is responding.
Exactly. So maybe taking what Mary just described one step forward and closer to what we try to present here today. So actually, at least those with sensory overresponsivity, and they're pretty much like the literature in children talks about 90% of autistic children that have sensory alteration, most of them probably sensory overresponsiveness. So actually, we argue that it's not just sensory overresponsiveness, it actually hurts.
Mm-hmm.
And everybody knows the experience of how it is when you ache, when it hurts. It's very hard to be engaged in any other activity amongst of socialization. So I think this is probably our main take-home message that we'd like to offer, to suggest.
Right, that it's physically painful to experience that, and right.
Exactly.
So our next question is about internal pain. So proprioception, sort of, or that internal pain versus external or acute pain. So does pain tolerance differ between, or has any of your research really touched on that?
So we actually studied only in the lab, I'm talking now. We studied only the somatosensory system, and more specifically, mostly heat pain, a little bit cold pain. We didn't test in the lab in all the methods we just described. We didn't test other modalities, so we can really bring like evidence what we tested, which is the somatosensory, specifically temperature, thermal, specifically heat. But I believe that in the qualitative, do you want to elaborate, Mary, if you have any other findings or evidence for different modalities?
Actually, the participants described the mainly external sources of pain and less internal sources. I do have to say that they mention the social pain, and this is, another branch of our study, which we did not elaborate today. But if you're interested to read more, you're more than invited to go and look for our article about social pain. So it is not exactly what you asked, but it is another branch we can look at.
Okay. So, and I misspoke earlier. I said proprioception, and I meant interoception. And so this next question is, they're just asking if you're intending to do some more research like this in the future, if this will continue, if you've got plans for any specific studies.
Of course. Dr. Granovsky, do you want to? You're muted. Yeah.
So, sure. We have some ideas to continue our studies. We had some ideas to look specifically, for example, on the issue of sex in pain perception and in neurobiology of pain in autism, for example. And it's one of the directions of our future projects.
And so, probably to capture other sensory modalities as well.
Sure. Yes, we have some preliminary results on it, and we're going to expand our methodology.
So your work is primarily children. Has there been any plan to look across different age groups, or?
So most of our work in autism is in adults.
Oh, I apologize. I misspoke. Sorry.
Yes, adults who are high functioning with autism. And yes, it's harder with the IRBs and everything in children because we're talking about pain research, but yet pain research is done in children. And yes, it's something that we are going to dive into.
All right, this next comment, they're saying in Scotland, we have 4 or 5 different methods to support people with autism to express pain. This may involve pointing to photographs which represent the severity of pain. There is one recognized assessment which staff, families, etc. can complete to capture what the person presents as when well as versus unwell or sore. I'm wondering if there are other worldwide strategies or assessment tools that you have found helpful or useful for gathering a picture of someone who has autism and is experiencing pain discomfort. I know you talked about that a little bit, but a lot of people wanted you to go back over that.
So actually, it's amazing to hear that. So thank you for commenting. Whoever commented, thank you for that. We in the lab, we use a 0 to 100 numerical, we call it numerical pain scale. And we train the participant how to work with that, how to translate it, what I feel, to a number. So in the lab, when we're doing experimental pain, this is the way that we're measuring it. I'd mentioned before that the experimenter or the researcher controls the intensity of the stimuli. Everybody gets exactly the same stimuli, and then we can measure the intensity of response. And this is by the participant saying, like, rating is pain intensity. And this is the behavioral research, the psychophysical approach. And what Dr. Granovsky showed, like in her aspect as a neurophysiologist, so she measures it in the EEG recordings, like she explained. Clinically, I think in Israel, you do observations and I think you use the FLAC. This is what I know of in Israel, working with observing pain in people that cannot really express. Yeah.
All right, the next question is just a clarification. They're asking, does TDC stand for typically developing control?
Yes, correct.
Yeah. This next question, if the autism is mild to moderate in symptoms and it doesn't have any self-injurious behaviors, then how can we say that they are hyposensitive to pain?
I'm not sure I got the question. If there's no self-injurious behavior, do we think that it is a hypersensitive?
Yeah,
not necessarily.
Yeah.
Not necessarily. I'm not sure I got it. Did you get it differently, Dr. Granovsky or Mrs. Levi?
Oh, actually, our cohort were the high-functioning autistic individuals. Actually, we think the opposite. I think that the self-injury behavior may be the way to reduce the pain, since it involves excessive motor activity, and motor activity is also a way to exert the endogenous inhibition to reduce our endogenous pain. So I don't think that two things are connected. Maybe I would suggest the opposite, that they are probably cannot exhibit, cannot show, or cannot complain on their pain, but they have some pain, some unpleasant feeling, and this causes them to demonstrate the self-injury behavior, and it's a way to diminish their pain, the internal pain.
And ARI has some.
And I want to add, please, that those behavioral manifestations not necessarily be connected or related to pain. I mean, it may be linked, as Dr. Granovsky suggested, but not necessarily, and it is important to declare it.
So maybe it is just to sharpen our message that we said that because our conclusion is that the pain system works okay, it is amplified, like the nervous pain system works okay, mostly. It is amplified, so they're hypersensitive and they less effectively inhibit, but in experimental pain, they do express the pain in line with their neurophysiological responses. However, from the qualitative research, we understand that the problem is in their awareness. So this is, and since to treat pain, you must be able to express it, here is probably the space that we mislook or overlook or not in line exactly with what's going on, because they do feel pain stronger, but do not communicate it regularly. And then we suggest, only then we suggest that maybe the way of communication is generally different from our expectation, and it could be by self-injurious or repeated movements and so on. This is, I think, what we tried to deliver.
Okay. Have you got any information about neurofeedback training or its use in managing pain?
So actually, Dr. Granovsky and me and some other, we published a paper about neurofeedback in adults with sensory overresponsivity, otherwise healthy, and it worked. Neurofeedback in pain, there are publications in all kinds of chronic pain syndromes, not many, but it is has been tested in chronic pain conditions, and it works. And in autism, I don't think it was tested yet. And it's one of our future directions when we talk about mechanism-based therapy.
Interesting. Okay. So does there seem to be a difference between perception of tactile pain versus interoceptive perception? And we talked about this a little bit, but I mean, in your studies, did you find anything quantitative that could detect that?
Dr. Granovsky, do you want?
Could you repeat the question, please?
Just the difference in EEGs or different monitoring systems between tactile pain and internal pain.
Again, I don't think that we have any information about internal pain. We used and worked with experimental pain.
Heat and cold, yep.
And as I showed in my presentation, we do find the correlations between some EEG parameters and pain sensitivity. So it's actually the objective way to look and to quantify the subjective sensation, subjective pain perception. So we do find some relationships.
Right. And I'm getting this question over and over, so I want you to repeat that information. But yes, for the experiments, it's difficult for them. They're explaining it's difficult can't apply a lot of tactile pain ethically. That would be difficult to do. So, okay. But there are so many questions here. So we're probably not going to be able to get to all of them, but I'll try to ask three more. I'll pose three more, and then maybe we could have the three of you back sometime soon to address some more of these. This person's asking about when you have an adult who is 22 and nonverbal, and you're trying to assess if they may be experiencing pain, where would you suggest they be seen? Is there a clinic that you send them to, or would an occupational therapist be the best person? Where can they get some help trying to assess that patient?
I would suggest to try and find an occupational therapist working in pain clinic. in a pain clinic. And I think I know that occupational therapists that work in pain clinics, they come across autistic patients that are aching. Many times were not diagnosed autistic, but they can do, I think, a not bad assessing, evaluating, and to try and see the pain there and autistic characteristics and the way it's interwoven. So I would actually recommend, again, to go to an occupational therapist in a chronic pain clinic.